see the slides now?
Can everyone see? Shall I start?
Oh, it went back to... I think it went back to your middle screen.
Yeah, that's fine.
Okay.
Shall I start?
Yes, you can. Thank you everyone for waiting. Sorry.
Okay. So, we finally started. Sorry guys for the delay. Finally got on track with the technology and stuff. If you have any questions, just kind of shout out, or you can wait till the end if you want, whichever, I don't mind. So my name's Zeinab. I'm one of the ST4s, Obs and Gynae ST4s in Wigan. And just going to do a quick whistle-stop tour through contraception because it is a huge subject, and I'm not sure. I mean, there's just so much. So I've tried to pick a few things out that might be important or interesting or something that we could go through. So what we'll go through today is the UK MEC criteria, different types of contraception, postpartum contraception, emergency contraception, and a few drug interactions as well. So has anyone heard of the UK MEC criteria? Yes, no, maybe? Shall I open this and see if people are answering on the group?
We've got some yeses and some nos.
Okay. So let me just work out if I can get the chat on my phone. Divya, can I hear everyone else in this group?
Everyone, no, they've got their microphones off.
Okay.
So it's just they're going to use the chat button to speak to you.
Right. Let me just get this on my phone then so I can use the chat button. Anyway, so UK MEC criteria is generally what we use in the UK for working out whether contraception is suitable or not suitable. So basically, there's 4 categories. Number 1 is one that you can use freely. There's no restrictions and no problem using this contraception for this patient. Number 2, there are, you think that this patient might have a background or some conditions which may make you think twice about this contraception, but overall, advantages outweigh the risks. UK MEC 3, generally the risks outweigh the advantages, but if you really, really want to start this contraception, you should probably get senior advice or consultant advice. And number 4 is completely unacceptable. So basically, yes, maybe yes. Yes, maybe yes, maybe no, and then no, essentially. So UK MEC guidelines are huge. There's like 11, 12 pages of just of tables and tables of what's appropriate and what's not appropriate to prescribe. But generally, the important ones to know are what you can't give and what you definitely can give, just for your daily practice. And so these are some of the UK MEC 4 criteria. So, for example, just to pick one out at random, UK MEC 4 prescribing the combined oral contraceptive pill for migraine with aura. That would be UK MEC 4. Absolutely, you shouldn't really do that. Any questions so far? No? Yes? Divya, I'm just trying to log into the thing on my phone. So
no, you can carry on. We can have them put all the questions in the group, and then we can see it at the end.
Okay. So this is, like I said, you've got 11, 12 pages of UK MEC guidelines. And this is the UK MEC. This is examples of how the UK MEC is set out, basically. So you've got your conditions on a column down the left, and then you've got your different types of contraception at the top, and whether it's 1, 2, 3, or 4. So there's loads. It ranges from everything from postpartum to cardiomyopathy. So these are some different types of contraception. So I've tried to put pictures of ones that actually aren't that common. See whether you've seen them before, whether you know what they are. So, can everyone see where my mouse is? I'm not logged into the medal on my phone yet, so I can't see the chat. So if you guys want to take your mic off and shout out, put your mic on and shout out, that'd be great. Does anyone know what this one is? Anyone?
Not got any answers in the group yet.
No answers?
Nova ring, someone's answered Nova ring and vaginal ring.
Yeah, absolutely. It is a vaginal ring. Correct. What about this one here? Anyone? This one?
Someone's mentioned female condom.
Absolutely, yeah. So we don't really, these are the ones we don't really see that much, to be honest. And what about this one? This one's not as hard. What's that one?
We've got several saying patches.
Yeah. And do we think the patches are combined oral contraceptive or progesterone-only contraceptive?
We've got Beverly saying combined.
Yeah, perfect. And this one? Oh, it's got the name on it. It's diaphragm. Yes. So those are 4 that I think are less common. You don't see them as much, basically, but you're different types. You've got hormonal. So guys, put your microphones on, please. And you just shout out any hormonal contraception. No one? They have no. Oh, okay. I'll put it in the chat then. Yeah, perfect. Combined. What else? What are the hormonal methods? Yep. Yep, we've got combined, we've got progesterone-only pill, Nexplanon, Mirena. Perfect. So yeah, you guys have basically got them all. And then we've got the injection as well as the Depo-Provera injection. What about non-hormonal contraception? Copper coil, yep. Yep, copper coil, condoms, diaphragms. Perfect. So someone's put the ring here. Now the vaginal ring actually contains hormones. It's a combined hormonal vaginal ring. So what else? We've got barrier, copper coil. It's a method that we don't talk about as much in OBS and gynae. Natural rhythm method. So that's, monitoring your ovulation and your temperature and things like that. Yeah, someone's mentioned it here. Natural method, vasectomy. Perfect. You guys have all got it. So failure rates. So when we quote failure rates for contraception, we have to look at the typical use and the perfect use. So perfect use is quite different to typical use. Just look at an example. For example, the COCP, the most common contraception method used in the UK. Perfect use, absolutely perfect use, it's 0.3% failure rate. Okay. So if you use it perfectly, 99.7% effective. However, the average woman uses the combined oral contraceptive pill in a way that gives them a 9% failure rate. So it's very, very different. And if you look here, the most reliable contraceptives are your LARCs, so your long-acting reversible contraceptives, because there's very little human error involved. For example, once you've got your progesterone IUCD in, the typical use and perfect use is the same because there's no user error involved. Similarly for the progesterone implant as well, which actually has the best best success rate essentially. Okay, so you can see here, the only LARC that has kind of a very significant difference in typical use versus perfect use is the progesterone injection. And why do you think that is? Why do you think that is? Just write down in the chat box. Why is progesterone injection? Why is the typical use got such a higher success? Perfect, Victoria. Excellent. So again, it's the one of the few LARCs that has user dependency. So that relies on the woman going to wherever she gets her progesterone injection done. She has to go there kind of every 13 weeks. Okay, so that's where the user error comes in. Does that all make sense? Okay, so let's go through each of the methods of contraception in a bit more detail. So the combined hormonal contraception. So that involves the pill, the patch, the vaginal ring. Okay, it's the most common used method in the UK. The pill is actually the most common used method. But how does it work? So it stops ovulation, thins endometrial lining, and thickens cervical mucus. So those three things in combination should help prevent a pregnancy. And generally for the combined method, you take it 21 days on and 7 days off. So you have a 7-day hormone-free interval generally. Of course, some women in some situations, they run their combined hormonal contraception back to back. That's for different cases. But anyway, you can see this picture here, the actual effect of the combined oral contraceptive pill. Okay. So missed pill, this is something you get asked a lot. So it's something you get asked a lot in exams, in real life, just by generally anyone who you see. They always ask about missed pill. So these are just examples of some combined oral contraceptive pills. So if you miss a pill anywhere in the packet, or you're late starting the first pill of the new packet, you just take the missed pill as soon as you remembered. Even if you have to take 2 pills at the same time, you finish the pack as normal. Okay? No emergency contraception, no further contraception is required because you've only missed one. Okay? So one missed pill that you remember and take, and take it with the next one is fine. Okay? No, you don't need any emergency contraception. However, if you miss 2 or more pills in the first 7 days, so remember, with the combined contraception, you're 21 days on, then you're 7 days off. So you've got a 7-day hormone-free interval. Okay. And then if you miss 2 or more pills in the first 7 days of the new pack, then you have to take the most recent pill and the planned pill, and you need emergency contraception because you've had a hormone-free interval. So you've already had 7 days without hormones, without contraception. And then to miss two or more pills after that, your contraception methods are compromised. Okay. And you will need to take emergency contraception and use barrier contraception for 7 days. Now, if 2 or more pills are missed in week 2 or 3, okay, you take your most recent pill and you take the planned pill, and then you use barrier contraception for 7 days. Okay, now the reason why you don't need emergency contraception for this case is that you've not just had a hormone-free interval. You've not just had 7 days hormone-free. Okay, you're at least day 8, so you've at least had 7 days of hormones kind of as a backup. Okay, and if you missed 2 more pills in your last week, just omit the hormone-free interval and run your 2 packs back to back. Does that all make sense? Basically, at no point should you be taking more than 2 pills at any one time. Even if you've missed 3, you only take the most recent one and the one for that day. We'll go through it all again if you have any questions at the end, because I know sometimes missed pills are a bit complicated. So missed patch. So missed patch again. So you have your 21 days of your patch on and your 7-day hormone-free interval. So if you start your patch late, so you've had more than 7 days patch-free, more than 7 days hormone-free, you have to consider whether you need emergency contraception if you've had unprotected sex in that hormone-free interval. Okay? That's the first thing. Second thing is get that new patch on straight away and use barrier contraception for 7 days. So it's very similar to the pill, essentially, the principles. Now, if your patch has detached for less than 48 hours, or patch has not changed for less than 48 hours, that's fine. No additional action required. So basically, you'll see sometimes a scenario where someone tells you that they've noticed that their patch has fallen off, or their patch has become detached from whatever activity they're doing during the day, but they definitely had it on yesterday. That's fine, because it's been less than 48 hours that it's been detached, so you can just pop a new one on. Now, if the patch has been detached for more than 48 hours, again, it's similar to the pill. So if it's in the first week, you need emergency contraception and barrier contraception. And if it's in week 2 and 3, you need just barrier contraception and stick a new patch on. Okay, so again, similar concept to the pill. And the missed ring is exactly the same as the missed patch rules. Does anyone have any question about missed pills, missed patches, missed rings? Just scribble it down in the chat box.
Holly just asked a question.
What if you have unprotected sex in a hormone-free week? Do you need emergency contraception? So do you mean in general or just in case of missed pill, missed patch? So if you, Holly, do you mean if it's just generally if you're good at taking your pill and you're in your hormone-free week, are you still protected? Or do you mean if you missed a pill? Okay, I'll just come back to that question in a little bit then when Holly replies. So, risks and benefits of the combined hormonal contraception. So, does anyone know any risks or benefits? You can write them in the chat. What are the risks of combined hormonal contraception? Oh, yep. Sorry, Holly replied. So if you haven't missed any pills, would you need contraception that week? No. So you are protected in that week, because you've had the hormone on board for 21 days. So actually, in that 7-day hormone-free interval, you have a withdrawal bleed. Okay, and so you're protected because your endometrial lining is shedding essentially in that 7-day. So you remember your 7-day hormone-free interval is also when you get your period. Not taking a period because you're not ovulating, but a withdrawal bleed. Does that make sense? So we've got some answers here. We've got clot, yep. Reduces ovarian, endometrial and bowel cancer, correct. Can improve acne, perfect. Can potentially increase breast cancer risk, yep. Treats heavy periods, absolutely. Irregular menstruation, PMS, perfect. So absolutely. So treatment of menorrhagia, dysmenorrhea, PMS, endometriosis, and PCOS. These things can all be helped by the combined hormonal contraception. So it can be life-changing for some women. And you're absolutely right, reduced risk of endometrial, ovarian, and colorectal cancer. Now, your risk of VTE, so your background risk of VTE is about 1 to 2 in 10,000. Generally, depending on what preparation you use, but generally, your risk of VTE is increased to 9 to 10 in 10,000, which is quite a significant jump, isn't it? It's about five times higher than the background risk. And also, with enzyme-inducing drugs like rifampicin, like carbamazepine, the effectiveness of the combined oral contraceptive pill is reduced. So you have to think about whether this is the right medication or whether actually the risk of pregnancy is a lot higher with the enzyme-inducing drugs. And it also reduces the effectiveness of lamotrigine and lowers seizure threshold. So anyone on lamotrigine should not be given the combined oral contraceptive pill because they're at higher risk of having seizures going forward. Effectiveness of combined oral contraceptive pill reduces in women who've had bariatric surgery. That's to do with the absorption. There we go. Any questions about the combined pill? So someone's written here STIs. What do you mean by STIs? Because we're not. Do you mean because we're not using barrier contraception? Okay. So let's go on to the progesterone-only contraception. So how does this work? Again, inhibits ovulation for the most part, thickens cervical mucus, and prevents implantation. And you've got 3 types. You've got your progesterone-only pill, you've got your implant, which is your Implanon or your Nexplanon, and your progesterone-only injection, which is your Depo-Provera injection, which take every 13 weeks. I know the coil is in there, but we'll talk about the coil separately as an intrauterine device, don't worry. So you take your pill, you take it once a day around the same time. Now, the traditional pills you had to take, within 3 hours of, so if you took it at 12 o'clock today, the latest you could take it tomorrow is 3 p.m. and that's like at a push, okay? It has to be at the same time every day. However, with the newer progesterone-only pills like desogestrel, the window is 12 hours, so you've got a bit more flexibility there. So the most common POPs available in the UK, you've got norethindrone, levonorgestrel, desogestrel, but they all have different brand names. There's loads of brand names. Let's see if we can see. These are just some examples of brand names that are out there, but they all have the same mechanism. Okay. Now, desogestrel actually is the best at suppressing ovulation, whereas the other pills are 67% success at suppressing ovulation. I've got a question here on the group. I'm just having a look. I was just wondering, in week 3, if you've taken the pill correctly for the 14 days before, why would you need to then use other contraception for 7 days following? Is there not 14 days of hormone on board that you have taken, so would be protected? Okay, yeah. So, yeah, you can. You're technically right. So we generally, if you've got 7 days of hormone on board, technically you should be covered. But just for kind of to cover you, because remember, sperm can last in the female genital tract for 5 to 7 days. So if you then stop taking it and you've actually got sperm in the genital tract, you run the risk of actually getting pregnant after you've had intercourse. Does that make sense? Okay, so missed pill. So we'll go through this again. So if you've missed one pill, so that's either more than 3 hours or more than 12 hours, you take your missed pill as soon as you remember, and you only take one pill. So with the missed progesterone-only pill, you don't take 2 pills at one time. You just take that one that you've missed. And then you have to use barrier contraception for 2 days after getting back on track with your missed pill. And you use emergency contraception if you've had unprotected sex after the missed pill and within 48 hours of restarting. Okay, so you've got a lot less time to play with basically with your missed pill. You're talking about 48 hours. Okay, so risks and benefits of your progesterone-only contraception. So it's very good in treating dysmenorrhea and menorrhagia, but it can cause a bit of irregular bleeding. Okay. Now, it's got no association with increased risk of breast cancer, and fertility comes back extremely quickly when you come off the pill. Okay. Now, the big thing is that it can be given to women up to 55 years old, whereas with a combined hormonal contraception, you wouldn't generally like to give it to someone who's over the age of 50, just because your risk of VT increases significantly as you get older. Plus, giving you estrogen, the risk of VT, the risk outweighs the benefits of it. Now, what people struggle with progesterone is sometimes you have quite significant mood changes and weight gain. Now, no causal link has been established with weight gain and progesterone-only pill, but a lot of people do report it and do struggle with it. And then your 10% risk of ectopic pregnancy, falling pregnant on POP. I've got a message here. Are there any reports for contraceptive guidance? What do you mean reports? Okay, now let's go through the implant. So your implant is your long-acting reversible contraception. You can see how big it is there. It looks like a little matchstick, and it's licensed for 3 years. It's inserted 8 centimeters proximal to the medial epicondyle of the humerus. So about there in the picture, basically. You can see where it's inserted. And generally they used to give Implanon, but now they give Nexplanon, because if you can no longer feel your implant and you want to make sure it hasn't migrated or gone anywhere else, then actually the Nexplanon is radio opaque, so you'd be able to do some imaging for it. Initially, you release quite a bit of progesterone, 60 to 70 micrograms a day. Then obviously it decreases as you get on, and by the time you get to year 3, you're on 25 micrograms a day, which is why you have to then replace it. So the risks and benefits of Implanon. So it's reversible, okay? So you can take it out easily, and when you take it out, your fertility returns fairly quickly. It's also a very good option for dysmenorrhea. So progesterone really does help painful periods. 20% of people don't have periods anymore. They become amenorrheic, okay? However, 20% also have the implant removed because they have irregular bleeding that they just find it unacceptable. And generally, that's the case for most progesterone-only contraception. It's the same for the coil, the pill, the implant, and the injection. Some people have no periods, and some people have unacceptable irregular periods, and some people have regular light periods, basically. Progesterone has little or no risk of VTE, which is a major plus if you're looking at someone who's overweight, has a family history, is a smoker, any risk factor that might predispose them for VTE. And you can also give the progesterone implant for people who are obese, so up to 150 kilos, whereas actually with the combined hormonal, you probably wouldn't give it to someone who was that overweight because of the risk of VTE. Like I said before, if you're not able to palpate the implant, the new Nexplanons, you can do imaging and work out where it is. If you can't see on imaging, you take some etonogestrel, okay? So you take a blood sample to test etonogestrel, which is the hormone in the implant. And if it's negative, the implant is, it's not in the body. It's migrated outside of the body somewhere. It's made its way out. And if it's positive, you have to think about doing an MRI just to have a little look where this implant might be. Okay. Next, progesterone-only contraception. We've got the injection. So that's generally we give the Depo-Provera, which is your IM injection. Okay, and it's given every 13 weeks. It's very good for treating endometriosis. And again, like I said, like the other progesterone-only contraceptives, it can induce amenorrhea for a lot of women. It's also the best and the most frequently used contraception for sickle cell sufferers, okay, because it reduces pain and severity of sickle cell crises. So it's what's recommended for women with sickle cell disease. Now, again, can cause irregular bleeding pattern, but that's the same with all these progesterone-only contraceptions. Okay. Now, the interesting thing about the injection is that we generally don't like giving it in adolescents, teenagers, young women less than 18 years old, because it can cause loss of bone mineral density, which means that it can affect kind of bone growth in those teenage years. So we generally don't like to start the injection very young. Okay. Now, this is the only one that causes a delay in fertility to return. So it can be up to a year after you stop your injection that your fertility comes back. So that's an important question. If you want to start someone the injection, you ask them if they're planning on getting pregnant anytime soon, because if they are, in the next 12 to 18 months, the progesterone injection probably isn't for them. So here we go, late injection rules. So actually, you can go up to 14 weeks. Generally, it's every 13 weeks you have your injection, but really you can go up to every 14 weeks. And then if you go to 14 weeks bang on, that's absolutely fine. Now, 14 weeks plus 1 day, you give your injection and you use 7 days of barrier contraception, okay? Now, if you've had unprotected intercourse, you need emergency contraception and barrier contraception. Now, the interesting thing about emergency contraception is that your LO1, so your ulipristal, may be less effective because you've got residual progesterone. You shouldn't really give LO1 if you've been taking progesterone contraception generally anyway, but we'll go through that in a couple of slides' time. So we've done the combined hormones, we've done progesterone hormones. Let's go on to the intrauterine devices. So copper coil, how does it work? So The copper coil, it's the effect of the copper itself on the ovum and the sperm, and the copper causes an inflammatory action in the endometrium, which prevents it prevents implantation, basically. And copper is also it's the copper content in the cervical mucus stops the sperm from getting through. Okay. Now the copper coil is licensed 10 years. It's radio opaque again, so if you lose it, you can image and see where it is. Now the progesterone intrauterine system. So there's 4 out there on the market. They all use levonorgestrel, and there's 4. So you got your Mirena, your Levocert, your Jades, and your Kyleena. Now the way they differ is basically an amount of progesterone that they have in them. So Mirena and Levocert have the most, 52 milligrams of levonorgestrel, and they're both licensed for 5 years. I think the Mirena is slightly it's licensed for a few more things than Levocert. For example, menopausal endometrial lining protection, but don't worry about that. Now Mirena is very good for someone if they want contraception, and they also have heavy periods, because it actually causes a lot of women to have very light periods or become amenorrheic. Okay. Now your Jades and your Kyleena have a lot lower concentration of levonorgestrel, so they're actually mainly licensed for contraception. They're not licensed for treatment of heavy periods, whereas Mirena is your gold standard first line treatment of menorrhagia. And they differ slightly by like 0.5 centimeter in size between them, so nothing, not too significant. That's just pictures of, so you've got your Mirena here, which looks slightly longer and slightly thicker in the body here than the others. Then you've got your Jades, which is your smallest amount, which is your lowest concentration of progesterone, and your Kyleena. So you can see that's the largest one, Kyleena, then Jades. But again, not too different in size. So going through risks and benefits of your intrauterine devices. So your copper coil is very good for contraception because of the copper toxicity to the sperm and the ovum. And a lot of people choose it because they don't want hormones. A lot of people don't want exogenous hormones in their bodies, so then they go for the copper coil. However, the copper coil is not good for periods, essentially. So it causes very heavy bleeding and quite painful bleeding, and can cause irregular bleeding. So if someone comes to your clinic and tells you they're bleeding really, really heavily, their periods have got so much heavier in the last year, and then you find out they're using the copper coil as contraception, there you go. That could be your cause. Try it and offer them something different. And with the progesterone intrauterine device, you've got a lot fewer side effects than any systemic progesterone, but it can sometimes cause irregular bleeding, like we discussed. It can also cause acne, breast pain, headache, but to a lower extent than the systemic progesterone. And there's some evidence that it can cause functional cysts in some women. Okay. Now, like I said, the copper coil, people like to use it when hormonal methods are contraindicated. So the stats at the bottom are for both copper and Mirena, copper and Kyleena, whatever. So its general risk of expulsion is 1 in 20. However, that's mainly in the first month or so. After insertion. Okay. Your risk of PID is 1 in 100. Risk of perforation is 1 in 20 as well. Okay. Sorry, that's wrong. Your risk of perforation is 1 in 1,000, not 1 in 20. I think I've just written that twice. Risk of expulsion 1 in 20, PID 1 in 100, and perforation is 1 in 1,000. So that was a kind of a real whistle-stop tour through the basics of contraception, what they do, and kind of which one is suitable for which type of people. So let's go through postnatal contraception, because it's a really big issue, and a lot of women get pregnant very soon after they've had a child. And actually, WHO recommends inter-pregnancy interval of 12 months, because a pregnancy interval of less than that actually increases both your neonatal and maternal mortality. Sorry, morbidity, not mortality. So that's your preterm birth, fetal growth restrictions, stillbirth, and neonatal mortality. These are all increased by getting pregnant very quickly again after giving birth. So 1 in 13 women conceive within the first year of childbirth, and 1 in 3 term pregnancies were unintended pregnancies. So those are interesting statistics, I thought. And this is from the UK MEC as well. So we can look through these. So the UK MEC sets it out very clearly. You've got postpartum women, and it's broken down into breastfeeding and non-breastfeeding. Okay. Now in breastfeeding women, implant is all fine. Okay. Generally, progesterone's fine. Okay. But in breastfeeding women, within the first 6 weeks, the combined hormonal contraceptive is a UK MEC 4, which means it's absolutely not allowed. Okay. Because your risk of VT is much higher. And then it kind of gets downgraded to a 2 before 6 months, and then a 1 after 6 months. Okay. So you can have a little look through that. That kind of works through everything. Important ones to note are your combined hormonal contraception. So I would advise you to look at the difference between a breastfeeding and a non-breastfeeding woman, okay, with the combined hormonal contraceptive, and also intrauterine devices postpartum. Okay, so intrauterine devices can either be inserted immediately after giving birth, within 48 hours, or after 4 weeks. Okay, that period after 48 hours, but before 4 weeks, your risk of perforation is extremely high because you've got a very soft uterus that is trying to involute. Okay, so it's either immediately or wait 4 weeks, essentially. And this is a image of a coil being put in at section. Let me click on this link. Can everyone still see this link? Bear with me a second. I've just found this video on the RCOG website. Can everyone see this?
After delivery of the baby, remove the placenta as you would normally and massage the uterus to aid contraction. Apply green armitages to ensure hemostasis of uterine angles. Ensure the uterus is empty of placenta and membranes. You do not need to exteriorize the uterus, but this is an option if you prefer. Remove the IUD from the inserter and grasp it with sponge-holding forceps or with your sterile gloved hand. Place the IUD at the fundus, pressing on the top of the uterus with the non-dominant hand in the same manner as applying fundal pressure. Once the IUD is in place, guide the threads of the device down the cervix, using sterile forceps if necessary. Then suture the uterus as you normally would. Do not suture the device.
Do not suture the device. There we go. So that was a coil being put in at section. And this is just, so that's what it looks like a section. I'll just show you a quick demo of how you put a coil in, either immediately postpartum after a normal vaginal delivery, or obviously in an outpatient clinic setting. So let's find that.
Or other contraindications, infections, or other contraindications for the insertion of cervix, and then cleanse the cervix, and vagina with a suitable antiseptic solution. Cervix, visualize the speculum, visualize the cervix, and then cleanse the cervix and vagina with a suitable antiseptic solution. Grasp the anterior lip of the cervix with a tenaculum to stabilize the uterus. If the uterus is retroverted, it may be more appropriate to grasp the posterior lip of the cervix. Gentle traction on the forceps can be applied to straighten the cervical canal. The forceps should remain in position, and gentle counter-traction on the cervix should be maintained throughout the insertion procedure. Advance uterine sound through the cervical canal to the fundus to measure the depth and confirm the direction of the uterine cavity. If difficulty is encountered, consider dilatation of the canal. Insertion. First, open the sterile package completely. Then use sterile technique and sterile gloves.
So this is the applicator.
Mirena is provided within an inserter consisting of the Mirena itself, already in the correct horizontal position, an anatomically curved insertion tube with a double-sided centimeter scale and a plunger inside, the flange, and the handle containing the mark, the slider, and the threads inside. Push the slider forward in the direction of the arrow to the furthest position to load Mirena into the insertion tube. Do not pull the slider downwards, as this may prematurely release Mirena. Once released, Mirena cannot be reloaded. Holding the slider in the furthest position, set the upper edge of the flange to correspond to the sound measurement of the uterine depth. While holding the slider in the furthest position, advance the inserter through the cervix until the flange is approximately 1.5 to 2 centimeters from the uterine cervix. Do not force the inserter. Dilate the cervical canal if necessary. While holding the inserter steady, pull the slider to the mark to open the horizontal arms of Mirena. Wait 5 to 10 seconds for the horizontal arms to open completely. Advance the inserter gently towards the fundus of the uterus until the flange touches the cervix. Mirena is now in the fundal position. Holding the inserter in place, release Mirena by pulling the slider all the way down. While holding the slider all the way down, gently remove the inserter by pulling it out. Cut the threads to leave about 2 to 3 centimeters visible outside of the cervix. Mirena insertion is now completed. Removal, replacement. Mirena is removed by pulling on the threads with the forceps. You may insert a new Mirena immediately following removal.
There we go. So that's your insertion. Looks very different, doesn't it, after a section and in an outpatient setting. So that's your intrauterine devices. Now let's look at the lactational amenorrhea method. So this is a method that a lot of women use when they're breastfeeding. So there's 3 criteria that have to be met to provide adequate contraception. So you need to be exclusively breastfeeding. That means regular feeds, no bottle top-ups, and no dummies, okay? You need to be amenorrheic, so you need to not have had a period since delivery, and you need to be within 6 months postpartum, okay? Because if all these characteristics are fulfilled, you've got really high levels of prolactin, which inhibits the estrogen, if you look at the hypothalamic pituitary axis. And if that's the case, then it's 98% effective. So it's 2 in 100. 2 in 100 women will get pregnant using this method. Okay. So, emergency contraception. So they've done postpartum contraception. We'll just go through emergency contraception. So when is emergency contraception required? So anyone who's got a risk of pregnancy after unprotected sex needs emergency contraception. Okay. So anyone who is not using any hormonal contraception should be offered emergency contraception. Anyone who is 3 weeks postpartum, okay, so your risk of getting pregnant is back from day 21 and from day 5 after termination, miscarriage, ectopic, anything like that, okay, or if any regular contraception has been compromised. So those are women that need contraception, emergency contraception. So there's 3 types of emergency contraception. You've got your copper coil, okay, which obviously we've talked about how copper is toxic to sperm and the oocyte and prevents implantation. So the copper coil can actually be given up to 120 hours after unprotected sex, and it's the most effective method, and only 1 in 1,000 people get pregnant. Okay, now if we compare this to Ulipristal, which is which is brand name is Ella 1, and that delays ovulation. Okay, that can also be given 120 hours after unprotected sex, but it's 1 to 2 in 100 women will still get pregnant after this. And then third, if we look at levonorgestrel, which is commonly known as Levanel, this can be given 72 hours after unprotected sex, and 2 to 3 in 100 women get pregnant after taking this. Okay, so you can see there the copper coil is the most effective emergency contraception. And then it can also be, once you've got the copper coil in place, it can then just be used as regular contraception if the woman wants. So this is just a diagram to explain the kind of timing of the different emergency contraceptions. So let's go through it. So your maximum risk of pregnancy is ovulation and 6 days after ovulation. That's your maximum risk, and a day or 2 either side, basically. Okay, so here you can see that your maximum risk, ovulation, and 6 days after. Okay, now your copper coil can be given at any point because the copper is toxic to the sperm and the oocyte and prevents implantation. Okay, because the earliest time that something will implant in the uterus is 6 days after fertilization. Okay, now your Ulipristal can be given up to the onset of the LH surge, so here. But once the LH surge, once you've got the peak of the LH surge, that's it. Ovulation is going to happen, and Ulipristal can't do anything about it. It can't prevent ovulation at that point. It can't delay ovulation. Okay. Now, levonorgestrel, again, delays ovulation, just like Ulipristal, but it needs to be given before the LH surge has started. Okay. So that's why it's really important to take a good history of women if they're asking for emergency contraception, to work out when the last menstrual period was, when their probable date of ovulation is, so it's 14 days after your last menstrual period, yeah? And to work out what the best method of contraception is, because if they've already ovulated and they're already a few days past ovulation, then their best bet is actually the copper coil. So that's just which one you should give, basically. So let's go through drug interactions with emergency contraception. Another great thing about the copper coil as emergency contraception, it's not affected by any concurrent drugs. It doesn't matter what drugs you're on. Whereas women who are using enzyme-inducing drugs should be offered a copper coil. Okay. Now, some people say that you can give a double dose of the Levanel if they're using enzyme-inducing drugs. However, there's very little evidence to support how effective this is at preventing pregnancy with this. And you cannot give a double dose of Ulipristal. So any enzyme inducers, such as carbamazepine, your phenytoin, they should have a copper coil. Okay. Now, I mentioned this briefly earlier, that your Ulipristal, so your Ella1, can delay ovulation for at least 5 days. However, any progesterone, so if you start progesterone immediately after taking it, or if you've already been taking progesterone before the emergency contraception, it can affect how good this is at delaying ovulation. So you don't generally use progesterone-only pill within 5 days of the Ulipristal emergency contraception. Okay. So don't worry, guys, we're nearly there. Breastfeeding. Breastfeeding emergency contraception. So the Ulipristal enters breast milk. So if you're breastfeeding and you've taken Ulipristal emergency contraception, you need to pump and dump for a week. Okay, so discard your milk for a week. Yeah. There's a theoretical risk of increased perforation, like we discussed earlier, when you're breastfeeding. So it's something to consider if you're thinking about the copper coil. And breastfeeding has no limitations with a levonorgestrel. So with breastfeeding women, your best bet is probably actually a levonorgestrel. Okay, so Any questions? I've got 3 case studies. We'll go through it together. Get involved. We'll answer some questions. But anything at the minute you want to go through? I know we've done a very quick whistle-stop tour, and there's lots to talk about with contraception. Or should I just crack on with the case studies? Yeah, case studies. Yeah. Okay. So case 1, an 18-year-old para 1. So she's got a 1-year-old child who had a normal vaginal delivery. She attends her local sexual reproductive health clinic requesting contraception. Her first pregnancy was unplanned and she wants a reliable method of contraception. At the same time, planning for a further pregnancy in 12 to 18 months. Okay, so she's in a steady relationship, has been with the same partner for 2 years. Her periods are irregular, heavy and painful, and have got worse over recent months with a cycle of bleeding for 5 to 7 days. And then her cycles are lasting 21 to 38 days. She's also noticed increased facial hair, requiring electrolysis. She's previously been diagnosed with PCOS. She has no relevant family history and examination. Those are her numbers. So we want to pick a contraception for her. What factors, first of all, what factors are seeming important to you so far from this case? Age, yeah. One stable relationship, good. So we're thinking absolutely heavy periods, need to consider this, need to consider PCOS. Good. PCOS, perfect. Facial hair. What else? What are her plans for family? What do you think? Delaying next birth. Exactly. So that's key. We mentioned it earlier, delaying next birth for 12 to 18 months. So which one of these can we just rule out straight away, do you reckon? So you guys mentioned the factors. So she's in a stable relationship. So should we take condoms out then? Weight, what do you think about her weight? So let's take condoms out because it says she's in a steady relationship, has been with the same partner for 2 years. So let's take that one out. What else can we exclude out of this list? Rule out depot. So why do you want to rule out depot, Victoria? Perfect. Yeah. So Victoria's absolutely right. So you want to rule out depot because weight gain, but also she wants to start a family. So do you remember we discussed that depot, once you stop taking it, there can be delay in fertility for 12 months. So what do we think the answer is? What do you think she should be started on, bearing all these factors that you guys mentioned in mind? So we need something that's going to help with contraception. Yeah. Is not going to affect her fertility long term. Might help her heavy, painful periods. Maybe regulate her cycle and help with her facial hair. So we've got someone's put option 1. Anyone else agree, disagree? What do we all think? I think 5. So why do you think 5, Zara? Yeah, Zara, I can absolutely see where you're coming from, as in safer because of her weight and a risk of VTE. However, I would say COCP, because, so someone said POP is BMI too high for COC. So let's work out her BMI actually. Let's work out her BMI and then we'll go through the UK MEC. Yeah, so oh yeah, there you go. You guys are all right. So absolutely. So you've worked out her BMI is UK MEC 3. So her BMI is over 35. Absolutely. So you could, it depends whether you would, in clinic, it's very difficult to say, you know, hard and fast rule, but in clinic, you could offer weight loss advice and then the COCP, okay? Or you could start her on the POP. You're absolutely right. However, something that's clear in this history is that she struggles with PCOS, so facial hair, and also regulating her cycles. So her cycles are already irregular. So POP probably wouldn't help with cycles. So yeah, so basically this question is showing there's numerous different answers for this. So we've managed to rule out that we don't need condoms and we don't need a depot injection. Yeah. But it depends. This is all to do with patient consultation. So you would have to discuss with the patient whether she would be happy to try a progesterone-only contraception like the Mirena or like the POP, because she's already having irregular periods, and there's a risk, 20% risk of having further irregular periods with this. Okay. So if we want to start the COCP, we would have to ask for senior advice on whether this was appropriate. And if we wanted to start option 3 and 5, we would have to discuss with the patient whether she felt the risk of irregular periods was acceptable for her. Okay, so sorry guys, that was a trick question. Do you have any questions about this case? Because this is the most likely case you're going to come across, not something with a straightforward answer. Okay, so case 2. Miss Y is a 22-year-old nulliparous young woman who presents at a local sexual reproductive health clinic, having had unprotected sexual intercourse on day 16 of a regular 28-day cycle. She's in a new relationship, having had intercourse last night with her boyfriend. She has not had any other episodes of unprotected intercourse this cycle. She suffers from epilepsy and takes carbamazepine twice a day. She's otherwise well with no relevant family history, and those are her measurements below. So what are we thinking? What jumps out at you straight away about this woman? So she's looking for emergency contraception. Absolutely, Divya. So she's taking carbamazepine. So what do we think is not suitable for her than taking carbamazepine? She's day 16, absolutely. So she's ovulated, hasn't she? Yeah, so hormonal will have interaction. So do we think Levenel is suitable? What about double dose Levenel? Yeah, exactly. So what would you think? Would you say, actually, sorry, there's no emergency contraception suitable, you'll have to have a termination, or would you go for a copper coil? Discuss copper coil, absolutely. Good. So yeah, copper coil would be the most effective one for her for a couple of reasons. She's on carbamazepine, so she's on an enzyme inducer. Okay, so ulipristal is not appropriate. Levonorel, there's little evidence that that's going to work, especially, and you can't just double the dose. There's, again, very little evidence for that. She's also on day 16 of a regular cycle, which means that she has ovulation on day 14. Okay, so she's already ovulated. And remember, the mechanism of action of Levonorel and Ella1 is to delay ovulation. So we're already past that point. We can't delay ovulation. It's happened already. And the only one that is suitable after ovulation has occurred is the copper coil. Okay, last case, guys. I know it's 8:30. I know you're probably tired. Mrs. P, a 32-year-old para 4, so she's got 4 babies, has just delivered a baby boy, spontaneous vaginal delivery, following an unplanned pregnancy, having recently separated from her husband and entered into a new short-term relationship. She is 1 week postpartum and requesting a reliable form of contraception. She has a family history of VTE in a first-degree relative, but has never had a VTE episode herself. She is bottle feeding. Her puerperum, so the time around giving birth, has been uncomplicated, and she's keen to start contraception as soon as possible. And those are her numbers: height, weight, and blood pressure. So, what do we think? What factors do you need to consider in this case? Absolutely. VTE, breastfeeding, relationship, history of VTE, good. 1 week postpartum, excellent. So, looking at the facts that you've listed so far for me, what do you think we can rule out for sure? We can rule out a couple of those options already, can't we? So, yeah, so we can rule out the combined oral contraceptive. Why can we rule that out already, Divya? Absolutely. Absolutely. UK MEC4. She's only a week postpartum. So it's way too soon to start the COCP. Perfect. So we'll get rid of that one. What else can we take out? Rule out copper coil. Exactly. Why are we ruling out copper coil? When can you not give copper coil? Why have we ruled it out? Perfect. Yeah. So we can rule out copper coil because she is more than 48 hours postpartum and less than 4 weeks. So we have to wait 4 weeks for that. Perfect. Perforation risk. Good. So we rule out copper coil. We ruled out the combined pill. What else can we rule out? What else can we rule out on that list? There's another one we can definitely rule out. She can use barrier methods, especially if it's got a new partner. Yeah, definitely. Barrier methods is definitely an option. So we're left with the lactational amenorrhea method and the POP/implant. Excellent, Rinku. So we can rule out lactational amenorrhea because she's bottle feeding. So she doesn't really fit the criteria of exclusive breastfeeding, does she? So we can take that out. So barrier methods or the POP. What do you reckon? Either or? Do you think one's better than the other for this lady? Yeah, both are absolutely suitable. It would be up to the woman. Some women like to leave postnatal ward with something in situ, so like they like to leave with an implant or the pill in their bag or something definite, rather than having to rely on trying to go and get barrier methods. But absolutely right. Discuss shared decision. So that absolutely. So I think there's a couple of cases here that really need to be shared decision making, either with yourself and the patient, or with yourself, the patient, and a senior colleague. Yeah. So these cases just to show that contraception isn't always straightforward, just one answer. Okay. So, sorry. Thank you for listening. Thank you for being patient with me starting late and having technical issues. But do you have any questions? I know that contraception is a massive topic, and you could talk about each of those little subsections for ages. But please do look at the UK Met criteria. It's very extensive, so don't feel like you have to remember it all in one day. And Divya has my email address if anyone wants to get in touch with specific questions about contraception or about generally OBGYN training or whatever. But do you have any questions right now? No problem. Divya, how does feedback work on this?
So they'll get the feedback link directly to their email. So they'll fill that out and then they'll get their certificates.
Great.
And then we'll send them to you later.
Great. Thank you. So if nobody has any questions, then get in touch with Divya if you want my email address for anything OBGYN related. No problem, guys.
I believe we don't have any questions then. Thank you very much, Zeinab. It was really good. A very good session and very engaging one. So we hope to see you soon.
Thank you. Bye.
Thank you. Bye, everyone.